Hi everyone, welcome to Dr. Deepa's Learning Launch. Today we will be discussing a case in the fascinating world of endocrine pathology. So this is the papillary thyroid carcinoma, which is a classic type and also beautifully known as the nuclei of worlds. The most common thyroid malignancy is papillary thyroid carcinoma, which accounts for 85% of all thyroid cancers. It shows a clear female preponderance and it affects young to middle-aged women. And despite being malignant, it's a gentle one with a good long-term prognosis and often with more than 90% survival rates in 20 years. But don't be fooled by the delicate appearance. It hides the story of transformation at the molecular level where the ordinary follicular cells begin to dance in the tunes of BRAF and RET mutations and lose their calm symmetry. If you look at the etiology, the story often begins with radiation exposure, especially in childhood, such as survivors of Chernobyl accident. Interestingly, it's more common in iodine-rich regions like Japan and Iceland. Some patients carry inherited syndromes like P10 hematoma, FAP, and Cowden syndrome, making them more vulnerable to thyroid neoplasm. On the molecular front, we meet the main characters, which is BRAF V600E mutation, the most frequent, pushing the MAP kinase pathway into an overdrive, often indicating a more aggressive disease. The RAS mutations are also seen in the follicular variant and is more often indolent. The RET and the PTC rearrangements are often radiation associated. The TERT promoter mutations is the final step that worsens the prognosis and signals a recurrence risk. If you look at the clinical picture, clinically the patient presents with a painless thyroid nodule which is often ignored, and after months the cervical lymph node also enlarges due to an early lymphatic spread. Remember, PTC loves lymphatics. Most patients are euthyroid with a normal thyroid function. Distant metastases are rare, but when they occur they typically involve the lung and the bones. During surgery, one must be careful not to injure the laryngeal nerve, or hypoparathyroidism also can be a complication after the surgery. Grossly, the organ often has an ill-defined gritty cut, and owing to those tiny Psammoma bodies, they have a gritty cut scattered throughout the organ. So it may be multifocal or sometimes bilateral with a tan gray cut surface. Occasionally, there may be fibrotic areas or cystic chains. The gritty feel under the knife itself is an indication that you may be holding a papillary thyroid carcinoma. Under the microscope, the thyroid begins to whisper now, and we have see these delicate papillae with fibrovascular cores lined by a single layer of epithelial cells. But what makes the tumor unforgettable are its nuclei. The reason behind today's title. So they are enlarged, overlapping, and crowded. The chromatin appears to clear out, giving the classic Orphan Annie eye appearance, a name that is borrowed from the comic strip character with big eyes and empty eyes. You'll notice nuclear grooving, irregular membranes, and intranuclear inclusions where the cytoplasm invaginates into the nucleus sometimes. And these cells become whorled in some areas, and they have a mesmerizing spiral appearance. These are scattered across with also laminated calcification with glisten-like pearls under the light microscopy. Fibrosis and sclerotic stroma may be surrounded by these tumor clusters, and in lymphatic invasion is also seen. If you look at the IHC and molecular insights, when we apply the IHC, the tumor shows a positivity for thyroglobulin, TTF1, CK19, HBME1, galactin-3. These help to confirm the thyroid origin and distinguish the papillary thyroid from its mimics such as medullary carcinoma and metastatic lesions. On the molecular front, BRAF, RET, RAS mutations are often detected, not only for the diagnosis, and it is also for use for prognostication. Imaging correlation, the ultrasound usually reveals a hypoechoic nodule with ill margins and microcalcifications, which is often described as a cold nodule in the radioisotope scan. The MRI can delineate the extrathyroid extension and nodal spread, which is very crucial for the thyroid surgery planning. The variants that you should consider are the histological variants, the tall cell variants, the columnar variants. The tall cell variant is usually seen in the older one with BRAF positive and is more aggressive. The columnar variant has naked stacked columns and CDX2 positivity. The diffuse sclerosing variant of the young patients have more fibrosis and lymphatic infiltration. Warthin-like variant have oncocytic cells amidst the lymphoid stroma. The hobnail variant has loss of polarity, high-grade P53 positivity. So each of these variants have a unique biological behavior. Also important is to consider the differential diagnosis. Multinodular hyperplasia lacks the nuclear features, that is one differential. Graves' disease has scalloped colloid with no inclusions, that is how you differentiate it from Graves' disease. If you see NIFTP, it is an encapsulated follicular pattern with no papillae. Follicular carcinoma has no papillary nuclei. Medullary carcinoma has calcitonin positivity and thyroglobulin negativity. Poorly differentiated carcinoma, which is also differential, has necrosis, mitosis, and lacks the papillary architecture. The rule of thumb is, when in doubt, call it papillary only if the nuclei tell you the story. The prognosis is excellent. 5-year survival is at the tune of almost 90 to 95%. 10-year survival is around 90%, and even better survival even at 20 years down the lane. Recurrence varies from about 0.1 to 0.5%. Microcarcinomas has about 35% higher risk. Poor prognostic factors that have to be considered include an age over 45 years of age, tumor size greater than 2 centimeters. The presence of PTC in a male sex is usually of a poor prognosis. Extrathyroidal invasion at diagnosis is a poor prognostic factor, and combination of the BRAF and the TERT mutation is a poor prognostic factor. So the diagnostic pearl is, if you find Psammoma bodies in the cervical lymph node, think of metastatic papillary thyroid carcinoma. The nuclear features are classical, and fibrosis can be also seen in these tumor. So when you see the beauty under the chaos of the nuclear pattern of PTC, then you have to diagnose this as PTC. Stay tuned to Dr. Deepa's Learning Launch for more such videos. Thank you for watching.